So first, thank you so much for the invitation. My name is Sørensen von Essen, and I'm a PhD student at the Department of Neurosurgery at Odense University Hospital in Denmark. The overall topic of my PhD is shared decision-making for patients with high-grade gliomas. The project is built up by 3 individual studies, and I will in the following like to present to you our experiences and results so far. I have no conflicts of interest. So you've just heard Hilary talk a little about shared decision-making in general, which brings us forward to something more specific about shared decision-making in a neuro-oncological context. So this following presentation will be based upon the questions: what is the current knowledge on shared decision-making for patients with brain cancer and their families? And what are the patients' and families' needs and preferences regarding shared decision-making? So let's start with the current knowledge about shared decision-making for high-grade glioma patients. To investigate this, we performed a systematic review with focus on the patient perspective on involvement in decision-making. We also searched for the perspective of the family, but this did not retrieve any results. The search was carried out in the databases Medline, CNAL, SIGINFO, and Embase. And all study designs were eligible for inclusion if they met the inclusion criteria, defined as full text, published and peer-reviewed empirical studies with the patient population of adult high-grade glioma patients. This is our Embase search string. I know you probably can't read it on the screen if you're looking at your phone, but with the assistance of a research information specialist, we made a very broad search in the databases for any words related to high-grade glioma patients and patient involvement in decision-making. Our searches were unlimited concerning language, publication date, and study design. We retrieved 5,051 original records, which were screened for title and abstract, leaving 24 eligible for full text assessment. The vast majority of the excluded 5,047 records were based on studies regarding diagnostics, prognostics, or treatment related to high-grade glioma patients or other patient populations without any information on shared decision-making or patient involvement in decisions. A total of 4 studies were included in our narrative synthesis. There were great heterogeneity between the 4 included studies. The first study, by Diaz et al., was a quantitative descriptive study involving inpatients in the diagnostic phase, making decisions about receiving primary surgery or not. The study found that 50% of patients wanted to know everything about their illness, 23% wanted the most important information, and 27% wanted only the most critical information. They also found that anxiety scores were correlated to satisfaction with the information. The second study by El-Javari et al. Was a randomized controlled trial of a video-based decision support tool involving outpatients in unspecified disease and treatment phases. The decision in focus was a hypothetical future decision concerning the preferred level of care at the end of life. The study found that the use of a patient decision aid were correlated to the patients choosing less invasive treatments. It reduced decisional conflict and increased patient knowledge, and all the patients in the study valued the intervention. The third study by Luciari et al. Was a quantitative descriptive study involving inpatients diagnosed within 3 months prior to participating, and the decision in focus was non-specified treatment decisions. This study found that the patient experience and satisfaction with information and decisional support were correlated with better emotional well-being compared to patients who experienced unmet decisional needs. And finally, the last study by Bromedal was a qualitative study built on individual interviews with outpatients about to begin adjuvant chemotherapy. Like the study by El Jabari, the decisions in focus were non-specified end-of-life decisions. And this final study found that most patients preferred to be involved in decision-making, and no patients wanted to make the decision alone without considering the physician's expertise. If life prolongation was no longer an option, the participants anticipated that they would want to be more involved in the decision-making themselves. This leads us to the conclusion that high-grade glioma patients generally prefer to be involved in decision-making about their own treatment and care. That shared decision-making and tailored information can improve patients' emotional well-being, and that patient decision aids can potentially increase patient knowledge, decrease uncertainty, and affect patients' treatment preferences. Still, the evidence in high-grade glioma patients is very weak, and more research is needed in the area before we can make any firm practice recommendations. In addition, none of the studies we found considered the role of family members, nor included patients with disease recurrence. A more recent review with a broader scope on all neurosurgical patient groups draws similar conclusions, that we need more knowledge and that the use of a patient decision aid can have potential benefits for patients with brain tumors. Talking about shared decision-making in a brain tumor population, it is essential to consider the specific challenges that exist for this patient group. A review from 2019 concludes that many brain tumor patients experience a decrease in their cognitive functions and decision-making capacity along the disease trajectory. Similar findings are found in this review from 2020, which also highlights the need to involve the patient's family and consider surrogate decision-making for patients lacking decision-making capacity. To sum up, we need more knowledge. A part of our patients have a decreased decision-making capacity, and we need to consider family involvement. This leads us to the second of our initial questions. What are the patients' and families' needs and preferences regarding shared decision-making? We decided to explore this through a qualitative study of the experiences and decisional needs in patients and family members at the time of recurrent high-grade glioma, through semi-structured interviews with patient and family members based on a phenomenological hermeneutical approach to explore lived experiences. We included adult patients with an MRI-confirmed recurrence of high-grade glioma and assessed to be a candidate for both surgical and oncological treatment, meaning that there was a treatment decision to be made. With the consent of the patient, we also included the family member who the patient pointed out to be most involved in the decision-making process. We recruited our participants from 2 Danish university hospitals. We have included 15 patients and 14 family members in the study. 11 of the patients decided to receive surgical treatment, potentially followed by oncological treatment as well, while 4 decided on foregoing surgery and receiving oncological treatment alone. No patients in this study decided on foregoing active tumor treatment. We analyzed the patient interviews and family interviews separately and compared the findings in the final step of the analysis. This revealed 3 overall themes shared by both patients and family members. The themes were balanced information and a trustful professional encounter, hope and personal preferences, and the involvement of patients and family support. In addition, we found one sub-theme regarding family only, considering the caregiver experience and caregiver burden of being a supported family member. Which brings us to the preliminary conclusion that patients and family members prefer to be involved in decision making. Hope is essential, and patient and family members need tailored information, decisional support to clarify values, and a trustful relationship with the physician. Family support was found to be essential to the patient. As pointed out in this presentation, the existing knowledge on shared decision-making in a brain cancer context is limited, but the little knowledge we do have points towards patient and family preferences for shared decision-making. Therefore, we need to continue our efforts in providing our patients and their families sufficient decisional support. This could be by exploring further the decisional needs of patients and families, implementation and evaluation of shared decision-making in clinical practice, development and testing of patient decision aids, and family involvement, surrogate decision-making, and any other questions that may arise along the way. In my own PhD study, the next step is to develop a patient decision aid, building on our results so far and designed to offer decision support to patients and family members during the decision-making at the time of recurrent high-grade glioma. This is, to our knowledge, the first decision aid targeted this specific decisional situation. At last, I would like to draw your attention to the next Shared Decision-Making Congress that will be held in Kolding, Denmark in June 2020. And thank you so much for your attention.
Thank you, Helle. That was very, very welcome presentation and shows that there is a groundswell of work that's starting around shared decision making. But we have a long way to go.